Welcome to the image analysis of the lower leg, aka tib-fib. Image analysis guidelines for the lower leg state that the tibia should superimpose about 1/4 of the fibular head and about 1/2 of the distal fibula. Fibular midshaft should be free of tibial superimposition. The tibial midshaft is at the center of the exposure field. The knee and tibio-talar joint spaces are closed. The tibia, fibula, knee, and surrounding lower leg soft tissue should all be demonstrated within the exposure field. When looking at the AP projection, you want to determine if there's any rotation or not. And how you determine that is just looking at the relationship with the tibia and fibula. When there is internal leg rotation, the tibia will superimpose less than 1/4 of the fibular head and less than 1/2 of the distal fibula. In other words, the fibula becomes free of superimposition more so. When there's external rotation, just the opposite happens. The tibia starts to superimpose more of the fibula. Might be more than 1/4 of the fibular head and more than 1/2 of the distal fibula. When determining in this AP practice analysis, again, we're going to look at the relationship of the tibia and fibula. In this projection, the distal fibula is obviously clipped, so we're going to have to repeat for clipping the anatomic structures. Also, the distal fibula and proximal fibula are free of superimposition of the tibia. So therefore, we have some internal rotation. In order to correct this imaging, we need to realign the two-part IR so that we include all anatomic structures and externally rotate that leg to that true AP projection. Let's move on to the lateral lower leg projection. In the image analysis guidelines for the lateral lower leg states that the tibia should superimpose about 1/2 of the fibular head. The fibular midshaft should be free of tibial superimposition. Posterior aspects of the distal tibia and fibula should be aligned. The tibial midshaft should be demonstrated at the center of the exposure field. The knee and tibio-talar joint spaces should be demonstrated as closed. The tibia, fibula, knee, and surrounding lower leg soft tissue are to be included within the exposure field. Let's talk about rotation in the lateral projection. Conversely to the AP projection, when there is external rotation in a lateral projection of the lower leg, that fibular head of that tibia starts to become less superimposed. It's less than 1/2 of that fibular head that is superimposed. In internal rotation, the midshaft, the entire fibula becomes superimposed by the tibia. So, like I said, just look at that relationship between that tibia and fibula to determine whether the leg is in external or internal rotation. In this first practice analysis, you just want to take a look at this lateral projection and determine whether or not, one, do we have all our anatomic structures, and two, is the projection in a true lateral. In this projection, we do have our anatomic structures, however, the fibula is not in the position that it should be. It is entirely superimposed by the tibia. Therefore, the patient's leg was in internal rotation. We need to externally rotate that leg to get it into a true lateral projection. In our second practice analysis, we again want to look at, do we have all our anatomic structures? If we do, okay, we're good. So maybe our two-part IR is okay. If not, then we might need to readjust. Then we want to look at the relationship of the tib fib. In this case, the tibia is superimposing less than that one half of that fibular head, and that should let you know that the articulation is starting to open. We're in an external rotation. We need to bring that leg back internally so that we can get a true lateral projection. This concludes the tibia and fibula image analysis. If there's any questions, please feel free to reach out to me either at clinic or you may email me.